Good morning, everyone. Um, Thank you very much for staying on for this next session. I think this is the last rounds presentation of the summer, or until the summer. So today we've got a special guest, Michelle Keir, who is one of the adult congenital heart disease cardiologists from the ACHD clinic at the PLC, of which there are 5 cardiologists, and Michelle is the director. Michelle reached out to me about some cases of ACHD patients that have been seen in the emerge, and the fact that there are many more of these patients who are going to be showing up to our emerges over the coming years, and there are about 1,500 of these patients now in Calgary. So as per previous presentations, if you guys can put all your questions in the Q&A, I'll moderate and we can ask them all at the end. And now I'll turn it over to Michelle.
Hi there, everybody. Thanks for joining. And thanks for the introduction, Chris. There we go. Okay. So I'm just going to start with going through a little bit of information about the demographics of ACHD and what this population looks like and how they're all going to start showing up to the emergency department. And then we'll go through some cases and talk about tips for managing their common ER presentations. And I have no conflicts. So this is an old study, but this is a natural history survival study that was from the Czech Republic. And basically what it did was it looked at what the natural history of congenital heart disease would be without surgical techniques. And so if we look at these kids, before modern surgical techniques, almost 80% of those born with hypoplastic left heart syndrome would have died within their first month of life. And now most of these kids are living to adulthood, and we're starting to see the first cohort coming to the ACHD clinic. Half of the children born with tricuspid atresia, tetralogy of Fallot, AVSD would not reach their first birthday. So a lot of these kids used to die in childhood, but as modern surgical techniques have improved significantly, the population that we're seeing that are surviving to adulthood is quite large, and it's a newer novel population. So ACHD by the numbers. So this is data from Ariane Morelli in Montreal. And so the top slide is looking at children versus adults with ACHD. And you can see that over the 10-year period from 2000 to 2010, we now have many more adults living with congenital heart disease than we do children, because the blue line is kids. And the top is all congenital heart disease, and the bottom slide is complex congenital heart disease. And you can see that now we have, and the numbers have just been increasing further. So even though there's a robust pediatric cardiology program and pediatric emergency room physicians are really well versed in the management of these patients, they're now actually, the population has shifted to adulthood, and we're seeing many more of them. And so this is another slide just showing kind of the same thing. And this is, again, the average age of patients with complex severe congenital heart disease. And you can see from 1985, they were young, and a lot of them would die in childhood, but now the average age is kind of a young adult. And so the population is growing. And then this is also a really excellent slide because it looks at the shifting mortality in adult congenital heart disease. So if you look at the left, that was in the 80s, and this was the death rate stratified based on age. And so we used to see a lot of kids dying in early infancy and in early childhood. And now that mortality curve has shifted. And so the hope is that most people with simple to moderate congenital heart disease will be able to live to normal life expectancies. But we are still seeing mortality in kind of the 20s and 30s in patients with more complex. And so we know that these patients are coming and that their life expectancy is not normal, which means that they will have a high burden of healthcare utilization. And so if we look at the disease burden or admission to a hospital for congenital heart disease patients, and the red lines are adult patients, you can see that the number of admissions has just been increasing steadily. And this was before 2000. And we know that that number is just going up. And so we say about 10% of registered ACHD patients are admitted to hospital annually, and the majority of those admissions are for arrhythmia or for heart failure, and most of these patients will come through the emergency department. And if we assume that we have somewhere between 1,000 and 1,500 congenital patients, about kind of 20% of those would probably be severe, then that's a high number of patients that are coming in yearly. So I think the idea that these patients are very rare, and you may see one of them in your career, is definitely outmoded. And now we are seeing more and more of them. And so how do we manage them when they present with acute presentations? So I thought I'd move on and go through a few cases of emerge presentations, and then talk about kind of tips and tricks and pitfalls in managing these patients. So the first one, and they're all titled "Gone Wrong." So I'm giving away the punchline, but I think it's important to go through the anatomy and the decision making, and then kind of troubleshoot that. So this was a case in the GTA in Toronto peripherally. So it was a 24-year-old woman with complex congenital heart disease who presented to the emergency department with chest pain. And the history that was available is that she was born with tricuspid atresia and had a lateral tunnel Fontan. And I'll go through the anatomy of that in a little bit. So her initial examination was that her O2 sats were 87%, heart rate was 80 beats per minute, blood pressure was 90/60. And on initial examination, cursory examination, she had palpable chest wall discomfort that was worse with inspiration, but she was by no means an extremis on kind of acute examination. So the initial investigations, so I'll just point out some key things. So her hemoglobin was 120. So with a SAT of 87%, the question is that a new SAT of 87%? Does she normally saturate much higher than that? Or is she chronically mildly cyanotic, and then is she significantly anemic with a hemoglobin of 120? So that should flag that that is abnormal in a congenital patient with some degree of cyanosis. So either it's new cyanosis or she's anemic. Her platelets are 100. So often in these patients, because of passive flow to the heart, we see congestive hepatopathy in a lot of congenital patients, and we're seeing end-stage liver cirrhosis and even hepatocellular carcinoma in some of these patients. So having a mildly low platelet count is not totally abnormal. Electrolytes and creatinine were normal. Her troponin was 9. BNP was elevated for somebody that's 24, but for somebody with her circulation is not terribly abnormal. So again, all of the kind of normal things that we would do for heart failure don't really compute in adults with congenital heart disease, because none of them are really validated. So we know that a BNP is predictive over time. So if they have a rising BNP, that's predictive of poor outcome, but there's no absolute value or cutoff as to what's normal in a congenital patient. And often they do have BNPs that are elevated. Her D-dimer was also negative, and then her beta HCG was negative. So because of the elevated D-dimer and the inspiratory discomfort, a CTPE was ordered. So I'll show you the image. So this is just a still frame, and we'll talk about the anatomy. But so the CTPE reported a large filling defect within the Fontan circuit extending into both pulmonary arteries, and you can see the differential opacification of the pulmonary arteries there. And the decision in the periphery emerge was because of the large PE identified, because of her low O2 sats, her low blood pressure, they decided to thrombolyse the patient. So she was given thrombolytic and then transferred to the ACHD center in Toronto. And so I'll just based on the title, she didn't require thrombolysis. So let's just talk through the case a little bit more. So what is a Fontan circulation? So this is the circulation that's the surgery that's performed in patients with a univentricular heart. So basically they're born, instead of having 2 pumping chambers, they have 1 pumping chamber, and it might be a right ventricle, it might be a left ventricle. There's all sorts of different anatomic variations, but the idea is that they don't have 2 separate pumping chambers. So we use the one that they were born with to pump to the body, and then the flow to the lungs is passive flow. So, and there's usually multiple surgeries before they get to their completed Fontan, but the majority of adult patients would have had those surgeries in childhood, and then this is the circulation that they reach in adulthood. This first procedure was described by Fontan, who was the surgeon, in 1971, but it really didn't come into common practice in North America and Canada and even Europe until kind of the 80s. So the oldest patients that we're seeing with this circulation are in their 30s. And so there's lots of complications associated with it. So if you look at the top left, so this is the classic Fontan, and there's all sorts of variations of this, but basically what they do within the series of operations is they ligate the main PA from the heart. So they basically cut off the main pulmonary artery. And then in the classic Fontan, what they would do is they would take the right atrium and directly sew it to the pulmonary artery. So the blood flow goes from SVC, blue blood, IVC, blue blood, to the right atrium, which then goes directly to the pulmonary artery, which is cut off from the heart, from the main outflow tract of the heart, then goes back to the lungs, back through the pulmonary veins to the whatever heart it is, whether it's left or right, and then to the systemic circulation. So this was the first procedure described, and this is what they would initially do. But because of complications with arrhythmia and significant RA dilation, that became outmoded. And so either B or C is the circulation that kind of people that are in their 20s would usually have now. That doesn't mean they don't have the first type. This one here on the top right is called the lateral tunnel Fontan. So the idea with this one is instead of directly connecting the right atrium to the pulmonary artery, they still ligate the main pulmonary artery, but then the blue blood from the IVC is directed through a Gore-Tex tube, which does go through the atria, but is not really connected to the heart because there are some fenestration. There may be some fenestrations in here for offshoot flow, but usually it goes directly IVC through this tube up to the pulmonary artery, main pulmonary artery, and then the SVC is connected to the pulmonary artery. So blood flow again goes IVC, SVC directly to the pulmonary artery, which is ligated and cut off from the heart, which then goes to the pulmonary veins, single ventricle, and then body. And then the other option is something called an extracardiac Fontan, which is what this one is. And this is where they take a Gore-Tex tube from the IVC to the PA, and it's completely outside of the heart. And so it doesn't go through the right atrium. And the thought was with this initially was that it would cause less arrhythmias because of the artificial material in the atrium. And we find that that's actually probably not true, that they still have the same number of arrhythmias or atrial arrhythmias, but it's harder to get through to do an ablation with an extracardiac circuit. So you will see some of these, you will see some of these, and then patients that are in their 30s or 40s would have the A type. So the patient that we were talking about is a patient who had a lateral tunnel Fontan. So she had tricuspid atresia, so her right ventricle didn't form. And so basically this passive flow goes to the lungs, and they use her left ventricle for her single ventricular circulation. The thing that one of the key points is that low oxygen sats are really common in these patients. So because of hypoplastic lungs, because of abnormal flow, many of them have collaterals. So this is a coronary shot of a patient with Fontan. And instead of having multiple coronaries, she has a single coronary, and she's got kind of this nest of collaterals there. And so we see veno-venous collaterals, aortovenous collaterals, and then we see collaterals within the coronary circulations. So often they will have a lowish oxygen sat. So an O2 sat of an 87% in somebody with a Fontan is not terribly abnormal. So then what is the practical tip we can learn from this case? So basically she didn't have PE. She didn't have a thrombus in the Fontan. The problem was that the study wasn't gated properly. So because you don't have a pumping chamber that goes to the lungs, there's passive opacification with dye. And so image acquisition needs to be timed properly for both passive and asymmetric, because sometimes it goes into the right pulmonary artery as opposed to into the main. IVC and SVC flow to the pulmonary arteries. So this always requires a conversation with the radiologist so they understand the anatomy, they know the anatomy, and they can gate the study properly. Sometimes it actually requires simultaneous groin and arm injections to get an appropriate opacification. So whenever we see a CTPE report that reports a large filling defect in a stable Fontan patient, we're always very questioning of that because we know that often the CTs aren't gated properly, and so you always have to be questioning that result. And then also this patient was quite stable. And if you can imagine, her only flow into the lungs is from that passive chamber. And so an occlusive thrombus in that circuit and in the main pulmonary artery causes dramatic hemodynamic collapse because they have a preload dependent circulation. So a patient with a huge thrombus in the Fontan circuit would not be kind of walking and talking. Any questions with that one, or is it okay if I move on, Chris? Yeah. Okay. So the next case, so this one is also from Toronto, but this one's depressing. So heads up. So this one was a code STEMI gone wrong. So 20-year-old man. So he presented to an urgent care center, kind of walk-in clinic, with reports of a low-grade fever for approximately 3 days. And his initial anatomy was tetralogy flow with a transannular patch repair, and then subsequent bioprosthetic pulmonary valve insertion at age 16. So we'll talk about the anatomy of that when we get to that stage. So an ECG was ordered, and he's got sinus rhythm, but he's got right bundle branch block and significant right ventricular hypertrophy. And I think the trigger for the real concern was kind of this deep T-wave inversion anteriorly, which in retrospect was probably just a sign of right ventricular strain. But so here's where the saga continues. So I'm just going to go through it quickly as to what happened, and then we'll talk about kind of where things could have been done differently. So the urgent care doc, because of those T-wave inversions and because of kind of some ST depressions, called the STEMI team at a referral center in Mississauga. The interventional cardiologist then accepted the patient for urgent cath, and the patient was taken directly to the cath lab by EMS. Difficult groin access. So again, a lot of these patients, because they had pediatric surgeries, to put a baby on a bypass circuit, they, instead of doing a poke in the groin, they actually have to do a cut down. So a lot of these kids or young adults have femoral veins, femoral arteries that are not accessible because they had cut downs when they were kids. So we see femoral artery thrombosis and collateralization quite a bit. So because he had what was predictable groin access difficulties, he had a large retroperitoneal bleed. And important to note that he had normal coronaries on this cath. Because of the large retroperitoneal bleed in the cath lab, he becomes hemodynamically unstable. And because of a concern about RV failure, because a lot of people, all they can remember is tetralogy patients have a big RV. So they decided not to give fluids because they were worried about fluid overloading the patient. And so they ran norepinephrine peripherally. High dose. So then the patient gets intubated, central line inserted, and was transferred to an ACHD center. In CCU at the ACHD center, he was noted to be septic. He had Staph aureus bacteremia, was treated with IV antibiotics and fluid resuscitation, and was able to be weaned off of pressors. But the problem was that he developed pretty significant necrotic fingers on both of his hands and toes. Plastics got involved. He required bilateral amputation of his hands and then had secondary fungemia. And then at some point during the saga, he developed a significant brain injury. He never regained consciousness, and he died in CCU after a really prolonged stay. So this was really traumatic for kind of everyone involved. So I'll just go through a little bit of his anatomy. So this is tetralogy of Fallot. So what he was born with was VSD and then an overriding aorta. So the aorta is embryologically displaced to the right, and it kind of squishes the pulmonary artery and the pulmonary circulation. So you get some degree of pulmonary stenosis or RVOT obstruction, and then associated with that, you get RV hypertrophy. So then the surgery that he had is something called a transannular patch. So basically they go in and they repair the VSD, and then they cut open that RVOT obstruction. The problem with the surgery is that they cut open the RVOT obstruction, and most of them are left with free pulmonary regurgitation. And some point in early adulthood, late teens, they require a repeat surgery for implantation of a bioprosthetic pulmonary valve. So this is what this young man had. So he had a bioprosthetic pulmonary valve in there. So what was the real problem? So when he went to the urgent care center, he went with fevers and kind of feeling crummy. And this is not a great image, but this is a parasternal short axis echo of a similar patient. So aortic valve here, and this is the RVOT into the main pulmonary artery. And so this is the bioprosthetic pulmonary valve. And you can see there's kind of a goober flopping on it. So really what the patient presented with was endocarditis in his bioprosthetic valve. And then all of the iatrogenic complications happened kind of as a result of misunderstanding. And we've actually had a few patients that have presented with bioprosthetic valve endocarditis that was missed for various reasons. So what can we learn from this young man's tragic death? So I think the first point is that ECGs are always weird in congenital heart disease patients. So none of the normal ECG reading criteria are actually validated in congenital patients. They always will have some degree of hypertrophy. Their axis is going to be abnormal. So always compare to previous, and then also always consider the clinical situation. So again, this is a young man who kind of came in walking and talking and said that he felt crummy. He probably wasn't having a STEMI. If there's if there's artificial material in the heart, we should always be considering endocarditis, even if it's old artificial material. So we've had patients that have had VSD patches that were 20 years old that had a residual leak and developed endocarditis. So making sure we draw blood cultures before we're giving antibiotics, and making sure we're always treating it as not sepsis NYD. We're always thinking about endocarditis. And then I think the other important thing is to always respond to the situation at hand and don't overthink it. So this patient was bleeding out. Who cares what his anatomy is? Give fluid and blood products. So in an acute situation, you do what you normally would do and deal with it later. So then I'll move on to another case. So this one is a cardioversion that went okay, but could have gone wrong. So we'll talk about troubleshooting this one a little bit. So this was a 42-year-old gentleman who presented to the emergency department with palpitations and chest pressure. So his original anatomy was transposition of the great arteries with a mustard operation. And so I'll talk about that. His heart rate was 160 beats per minute. His blood pressure was normal, 130/70, and he was saturating fine. His home medication, so he was anticoagulated, so he was on apixaban 5 twice a day, and he was also on bisoprolol because he had a history of atrial arrhythmias. So this was his initial ECG. He was in an IART. He was cardioverted once, sedated and emerged, and went back to normal sinus rhythm. So this was a case where everything went okay, but what are the potential complications? So just the original anatomy of this person. So he had classic transposition of the great arteries, or what used to be called DTGA. So basically what that is SVC, IVC goes to the right atrium, right ventricle, but the great arteries are swapped. So your right ventricle leads to your aorta, and then pulmonary veins, left atrium, left ventricle, and then that goes to the pulmonary artery. So there are different operations that are done now, but about 30 years ago, the mustard or Senning procedure, also called the atrial switch, was the surgery that was done in these patients. So basically what they did was they would redirect the atrial blood flow. So they would make what's called a pantaloons baffle, so pants. So SVC and the IVC, they would create either a Gore-Tex baffle, or they would make this out of pericardial tissue. And so they would direct that to the left ventricle, which is over here, but then connects to the lungs. So the blue blood goes through this baffle to the left ventricle, which then goes to the lungs, pulmonary veins, and then the pulmonary vein flow, which is the oxygenated blood, goes behind this baffle and then through the systemic tricuspid valve, which then goes to the aorta. So you can imagine there's several problems with the circulation in the long term. So one is that these patients were left with a systemic right ventricle. So their right ventricle is pumping under systemic pressures. So RV failure is really common in these patients, and the majority of them, by the time they're in their 30s or 40s, will need a heart transplant because their systemic right ventricle can't pump to their circulation for a normal life expectancy. They also often have significant tricuspid regurgitation, and then they also can have baffle leaks and baffle stenoses, and then thrombi within the baffles. The other thing that's common because of all this artificial material in the atria is that atrial reentrant tachycardias are extremely common. The problem with that is that when one of these patients has an intraatrial reentrant tachycardia, they're also at big risk of having AV nodal block, complete AV node block after cardioversion. So it's common that after you cardiovert this patient, they may be converting 160 or 1:1, but then that you cardiovert them and they have a 5 to 10 second pause. And the problem with that is in this person, if you're in the emergency department and they're sedated, where do you put a temporary pacemaker wire? So if you were to put it into the arm, like we normally would, into the IJ like we normally would, it would have to go through this baffle and then all the way through this baffle into the subpulmonic LV. So you can imagine that that's not an easy route. So it's not an easy procedure done without fluoro. The other concern is that, so in this patient that I presented, he had a significant baffle stenosis here. So this baffle is completely occluded. So even if you were to try to put a temporary pacemaker wire in there, you'd get stuck. So you'd have to be then trying to put a pacemaker wire in from the groin through the IVC baffle and then into the subpulmonic LV. So there really isn't a backup strategy for this patient. The other thing is with anesthesia. So if you look at the echo, the systemic RV is mild to moderately down, but a systemic RV doesn't behave like a normal left ventricle. And so you would expect that they're at significant risk of hemodynamic collapse with anesthesia. So the bottom line is that this one went okay, but a mustard patient should always be cardioverted in the CCU with anesthesia support. And the other concern is that, yes, he was on a DOAC, but the evidence for DOAC in congenital heart disease is not particularly good. And so how could we possibly know that they don't have a thrombus in this baffle? So saying, yes, there's anticoagulated is not necessarily acceptable to rule out thrombus in these patients. And so this patient probably should have had a TEE, been cardioverted in the CCU with anesthesia, and then EP on call that they could put a pacemaker in. So what can we learn from this case? So I think that the most common is that nothing is ever simple in ACHD patients, and so call for help. Never sedate without anesthesia present and a backup plan. So I had a Fontan patient who almost died during IUD insertion because she vagaled with cervical pressure, and then she was preload dependent and she coded. So really no procedure is ever simple in these patients. If the patient is hemodynamically stable, always call for help if you have time. And then I think the other thing is that guidelines never apply in these patients. So there are congenital guidelines, but they're more for surgery. But what is really the risk of stroke or DOAC in one of these patients? So that's my time. So thank you guys for tuning in, and I'll just stop right there to see if there's any questions.
Yeah, Michelle, thank you very much. So there are a couple of questions. The first is basically two people asked the same questions, which is, can all of these patients have a care plan, or do they have a care plan that's in SCM and has their normal vital signs and what to do in the case that they present to the emerge?
Yeah, so in the past, they didn't, which was a real problem because all of their congenital clinic letters would live in our paper charts, which was a terrible solution. So now all of our clinic letters are on NetCare. So anybody that's been seen in the last 2 years, there is a letter on NetCare. And so that would be most of the complex patients, because these ones are all seen routinely every 6 months to a year for follow-up in the cardiology clinic. So all of them should have a letter on NetCare from congenital cardiology. And we're very careful that when we dictate the letters, we always dictate what their original anatomy was, what surgeries they've had, and then what their care plan is. And we always put recommendations at the end, like, this is what this person's at risk of, and if this happens, do this. So it wasn't always the case that they were in NetCare previously, but now they should be. And we're working really hard to make sure that the documentation is there. So if the patient is stable, you should be able to go to NetCare and pull up their last clinic letter and see all of that information.
Okay, great. Another question, and I have this one as well, but also from Katie Lynn, is we should likely be involving the adult congenital cardiologist for basically all of our acute and emergency presentations. Is there somebody on call during the daytime? What about after hours?
Yeah, so technically no. So that's the problem, is there's not enough of us to do a full call schedule. We're hoping within a few years, because we know that the number of admissions is going to rise. But we are, so, what happens sometimes, and I think this is a real problem, is that sometimes the emerge doc will call the congenital or the cardiologist on call, and they either say, oh no, call them in the morning, which if they're stable is fine. Or they'll say, oh, this doesn't sound cardiac, we don't need to see, or they'll see and kind of dismiss. So that is a problem that we're trying to deal with within our own division. But I think that we are always available. There's someone always on site during the day And most of the general cardiologists, I mean, they can communicate with us. So they have our cell phones, they can text us if there's something going on, and that happens a lot. So, at nighttime when somebody comes in and they're sick and it's a TGA patient, I'll get a text at 2 a.m. from the person that's reading echo saying, hey, can you take a look at this? And so no, we don't have a formal call schedule, but we always do carry our pagers, and one of us is always in the city. And so I'm hesitant to say page us anytime, but really you can page us even if we're not on call.
Okay. And yeah, then there's just another question from Patricia. Patty, is PLC considered the designated ACHD site for Calgary? Yes, it is.
Yeah, I think so. So our clinic is at PLC, and so the majority of patients will present to PLC because that's where they're used to coming. It is a real problem because we're disjointed from the EP service, so we have a lot of sending people back and forth. And EMS brings these patients to whatever hospital is closest, and often will bring them to Foothills because they have a prior cardiac history. So I think technically, yes, PLC is the designated center, but the four of us that still do call at all the sites. And so we are available to go to all the sites. They don't have to physically be at PLC for us to see them or get involved.
Right. And how do you best connect patients to your clinic? There apparently have been a few who've presented to the emergency department who don't have GPs or cardiologists.
Yeah, so that's common. Yeah, so with a young patient population, we lose patients all the time. There's a lot of literature looking at kind of the psychological aspect of being 20 and having a significant cardiac condition. And also they used to tell these patients that they were repaired or fixed. And so oftentimes they didn't know that they required long-term follow-up. So our clinic is at PLC. We're in the referral directory. We've had a few where the patients presented to Emerge. They don't necessarily need to be admitted, but the Emerge doc just sends us the sheet and then we find them. So if they need to be admitted, you can always call us for sure. If there's questions, call. And then you can always just fax to our clinic and we'll do the detective work and figure out whether they need to be followed, where they're followed, where their surgeries took place, that sort of thing. We do get a lot of patients come back into care that way. The other way we get a lot of patients is pregnancy. So for women, a lot of times they will be lost to follow up for a long time, and then they get pregnant and somebody goes, hey, this person needs to be seen by cardiology. But we're always happy to have even just a one pager saying, can you figure out who this patient is and where they're supposed to be? It happens often where we have patients with arrhythmia and they come in and sometimes they will say to you, oh no, I don't need follow-up, I was fixed, it's fine. But don't believe that. So sometimes they have a misinterpreted idea that they don't need follow-up. So we're always happy if you just fax the referral to us or fax whatever information you have, and then we'll do the detective work and figure out where they came from, what their anatomy is.
Okay. A few people have commented on the fact that so it's good that they have the Netcare notes, and thanks for that. But is there a way that can be put into SCM as well? Just because we do have Netcare outages for 4 hours at a time, at least once a month, and then we're unable to access that information.
Yeah, so they are in SCM as well.
They are in SCM as well?
We dictate on the UCMG system, so they are in SCM. Yeah.
Okay, great. Is congenital cardiology in ROCA?
No, we are not in ROCA. Yeah. So because we don't have a call schedule. So the best way is usually to call the clinic and see who's here that day, or you can page one of us personally. So it's myself, and I guess I'm volunteering to be paged 24/7, which is fine. Because to be honest, we'd rather be involved. There's, in these patients early because it prevents some of this stuff going down the line. And then Stephen Reynolds and Nita Guran, and also Michael Connolly. So there's the four of us. Nanette Alvarez is still around, but she doesn't do call anymore. So there's the four of us one of us will always be in the city, and we sign out our pagers to each other. So if you're calling one of us, and it will go to the pager of a congenital cardiologist, but we are not in ROCA because there's not enough of us yet to form a full call schedule.
Yeah, I think what I'll do is I'll chat with you offline about the call schedule and ROCA and that type of thing, and then we can disseminate that to the group and discuss it a bit more from what's come up today.
Yeah.
And we can also discuss the care plans in SCM because that's kind of a specific thing and we can chat about that. A couple of other questions. This is going to vary depending on the congenital defect slash subsequent repair, but how common is it that these adult patients are anticoagulated?
So very common,
Okay.
although we don't really have great evidence for it. So atrial arrhythmias are extremely common, and this is a question we get all the time: is that CHAD score does not count in these patients. We don't use it, so sometimes I'll have somebody in the periphery that'll say, "Oh, you don't need to be on this because your CHAD score is only 2," but none of that is validated for congenital patients, and we know the risk of stroke with IART is extremely high in these patients. So anybody that has an atrial arrhythmia with congenital heart disease, we tend to anticoagulate. The Fontans, so if all the Fontans in Europe are anticoagulated on spec, we tend not to do that unless it's an RA to PA Fontan, so that kind of first old one that I showed, because they're at high risk of thrombus. So a lot of them will be anticoagulated. The problem is that, and some of them will have mechanical valves as well. So we do have a lot of patients that have a mechanical valve and a Fontan. The problem is that the adequacy of that anticoagulation, so again, lots of young patients, so they don't take their warfarin, or they don't take their DOAC. And so even though there's not evidence for DOACs, we tend to do DOACs in a lot of these patients because they're just not adherent to the warfarin, won't get the INR checked. And then the other problem is like the mustard patient. So yes, he's on apixaban because I think that's going to help and prevent stroke, but does that rule out a clot there if he's an atrial flutter? Not really. And so we tend to still do a TE in some of these patients before we would cardiovert. So it's variable, yeah. But a lot of them are anticoagulated.
Okay. So, right. And I think the last question is, so yes, these patients are directed to go to the PLC emerge, but do anesthesia slash radiology know that we may need specific management or imaging for these patients, and do they have protocols for them?
So, so anesthesia, so no, but at the same time, I think probably because we do cardioversions on them, they're probably a little, so they're not comfortable. You have to go through it with them, or we have to call. So oftentimes it means calling us, and then we have a communication with the anesthesiologist to go through the anatomy. So no, they're not comfortable, but we can get them comfortable quickly. And radiology, so there is a specific Fontan protocol. I get a lot of, there is one radiologist at Foothills that's trying to make it citywide. There is a specific protocol. I get pushback a lot from radiologists saying, no, we know how to do it. We don't need you to tell us how to do the CT scan. But then we get a result that says there's a massive filling defect when there isn't. So I think just alerting them that they do have a Fontan, they have passive flow, please take delayed images after the injection. And then there are protocols that they should have, but you have to specifically make sure that they follow it. So I think even just putting, I'll put in a rec for an outpatient CT and say, this patient has a Fontan, please do delayed images, and we'll still get a result where it wasn't done the way that we had requested. So it takes a phone call and a personal conversation with the radiologist to get it done.
Great. Thank you very much. That looks like all the questions. So thank you very much again for doing this, especially on really short notice, and for reaching out to help us out. And I'll chat with you a bit more offline about some of the care plans and the call schedule and all that kind of stuff.
Great. Thank you.
Great. Thank you.